Hello again, this is again Luc Thomas speaking about squamous cell carcinoma, and this part will be dedicated to dermoscopy. So what dermoscopy can give you as informations in squamous cell carcinoma. First of all, I must say that information is less important and less useful than in pigmented lesions, but some insight can be given and it's interesting to look at it. First of all, what we are going to see are vessels. Vessels are present in the vicinity of the tumor, and the peculiar behavior of the vessels um, in the area of squamous cell carcinoma is interesting to consider. What we see are red blood cells inside the vessels, so it is important not to put too much pressure. Too much pressure will erase the vascular structure, whereas with less pressure, you will see them better. So a non-contact dermoscopy could be used, or gel dermoscopy is also interesting. The vessels we're going to consider in squamous cell carcinoma are the papillary vessels, but also the vessel of the subpapillary horizontal plexuses. Let's speak first about these vessels of the papillae. When the lesion is flat, and this is observed mainly in Bowen's disease, the papillae is seen from above. And this is why we have these glomerular vessels. These glomerular vessels have been called this way because they simulate the aspect of the glomerular apparatus of the kidney. And these glomerular vessels are characterized by their groupment in bunches. And if we enlarge the picture, it is possible to see this aspect looking like glomerulus. The second type of vessels do correspond to the same image. These are papillar vessels, but since the papillae are elongated, then you can see them not only from above, but also from the side. And this produces the image of hairpin-like vessels. These hairpin-like vessels are observed in the periphery of the lesion, but they do correspond to the same anatomical structure than the glomerular vessel, the papillae, seen from the side. So you have these vessels, and around these vessels you can see a whitish halo that corresponds to the epidermal component. Then keratin becomes oxidized and the color changes. It's not white but orange. And when this oxidized keratin is exposed to the air, the atmosphere, then it becomes whitish. Like the squales you can see, in the center part of this lesion. So these hairpin-like vessels, papillar vessels, seen from the side, are always with this whitish halo, and their aspect changes if you change the position of the dermoscope. It means that for some of them, you can observe them as hairpin-like vessels seen from the side, but a glomerular aspect is also possible if the angle of vision is different and you can see them from the top. In some cases, these hairpin-like vessels are in a very peculiar circular arrangement, and this is observed in this kind of crateriform squamous cell carcinoma with typical hairpin-like vessel with a whitish halo. Then keratin becomes oxidized and orange, and then this orange keratin is exposed to the air, and the inclusion of air inside produce this whitish aspect of the squames. But unfortunately, this is a confusing image because it's not specific. Papillae are also prolongated in different entities, all keratinizing tumors, including seborrheic keratosis. So in seborrheic keratosis, you will see exactly the same image. The other type of vessel that is observed in squamous cell carcinoma are the enlarged vessels of the subpapillary horizontal plexus. These vessels that are pushed up by the dermal tumor produce arborizing vessels. It is classical to say that these arborizing vessels are observed in basal cell carcinoma, but this is not true. In fact, every dermal tumor can produce these tree-like vessels, and it is also the case for squamous cell carcinoma. So again, we have a confusing image. These plexuses can be pushed up by basal cell carcinomas, of course, but also we have seen squamous cell carcinoma, but it's also possible to see the same image in an epidermoid cyst, in dermatofibrosarcoma protuberans, and many dermal tumors. The last aspect of the vessels we can observe in squamous cell carcinoma are formed by the neovasculature of the tumor. These neovessels are atypical because they are produced by the host in response to the tumor. And this is why we qualify these vessels are atypical vessels. These atypical vessels have three different possible definitions. The first one is polymorphous. It means that we have more than two types of vessels within the same lesion. A second possible definition is the presence of linear and irregular vessels. And the third definition is the presence of milky red areas. This is observed in squamous cell carcinoma, of course, and for example, in this lesion, you can see more than two types of vessels, arborizing, linear and irregular, corkscrew-like vessels, dots and globules, too much vessels to consider the diagnosis of a benign tumor. In this lesion, you have milky red areas, and these milky red areas also are observed in malignant tumor. It's the malignant, one of the three possible definitions of a malignant vascular pattern. But unfortunately, these aspects are also confusing and non-specific. You will observe an atypical vascular pattern in amelanotic melanoma, but also in ulcerated basal cell carcinomas, and unfortunately also in one benign condition, pyogenic granuloma. It is impossible to make the differential diagnosis between pyogenic granuloma and malignant tumors on the basis of dermoscopy. This is why histopathological examination of every identified pyogenic granuloma is necessary. So to conclude with this chapter on vessels, it is important to say that vascular semiology is less potent in diagnosis than pigmentary semiology. I make the comparison with the old times of neurosurgery when we made the diagnosis of brain tumors on the basis of arteriography. In that time, we had an indirect image of the tumor. Nowadays, we have MRI, and it's possible to see better the original tumor in the brain of the patient. The same comparison exists with vascular and pigmentary semiology in dermoscopy. With vessels, except in case of vascular tumors, what you see is vessels produced by the host in the stroma of the tumor, not the direct aspect of the tumor. Whereas when you observe pigmentary lesions, what you observe is the tumor itself, and you can give more conclusions from the last than from the first category of lesions. Another anatomic thing that is observed with dermoscopy is important in the diagnosis of squamous cell carcinoma. It's the squares. The squames are irregularly thick, and therefore their optical comportment, their optical aspect will be different on dermoscopy. But interestingly, as you can see on this image, they are better seen with naked eye examination than with dermoscopy. And this is normal because the purpose of dermoscopy is to eliminate the reflection of lights on the stratum corneum. This is why superficial squamous cell carcinoma, only composed of squames, are difficult to identify with dermoscopy, and this is why naked eye examination is often considered as more important. In squamous cell carcinoma, one can see some pigmentation. This pigmentation could be due to melanin, and this is often the case in Bowen's disease. But some of the pigmentation that is observed in squamous cell carcinoma is due to hemoglobin in purpura. And this purpura is often observed in the central plugs of keratin observed in thick squamous cell carcinoma. Then the squames become much thicker, and you have keratin plugs, and these keratin plugs have this typical orange color of keratin, and this is observed, for example, in this lesion with this orange plug. But some of the plug are in the follicular region, and this is typical of what we are observing in actinic keratosis. This aspect has been named the strawberry pattern, and it is due to these follicular keratin plugs. What is important to consider is their irregularity in the size of the keratin plugs, and of course the reddish background of the lesion. But again, the clinical vision is often more powerful than the dermoscopical image because all the purpose of dermoscopy is to reduce the optical impact of stratum corneum in the observation of the lesion. So this is a scheme of this fragola, the strawberry aspect. Some of the plugs go deeply into the follicles, and this produces a very peculiar image that has been described by Australian authors, and these are the white circles. These white circles are highly suggestive of squamous cell carcinoma and very interesting in the diagnosis of flat or slightly raised lesions. In some cases, these plugs go deeply into the dermis and produce cystic cavities. And these cystic cavities are filled with keratin, but since the keratin is not exposed to air, it's not orange, it's whitish. And this is what is observed in this lesion. Advanced cases of squamous cell carcinoma, as well as every advanced cases of skin cancer, is characterized by ulceration. And in this case of ulceration, you will see some bleeding or some crusting of the lesion. So now you have all the symptoms and all the clinical pathological correlations. We will go to the clinical situations. The two first are the early steps, actinic keratosis and Bowen's. So let's go to actinic keratosis. In case of actinic keratosis, what we see is very little with dermoscopy, since changes are observed in the stratum corneum. So this is why we will observe this reddish change in the dermis and the follicular plugs. But again, since dermoscopy works with the reduction of the reflection of light on stratum corneum, it's often easier to see the lesion with naked eye than with dermoscopy. Bowen's disease is different. In Bowen's disease, we will observe some changes in the vessels because the papillae are enlarged. And this is why in these flat lesions we observe these glomerular aspect of the vessels. So a typical Bowen's disease is associating irregular squamous, irregular in size and irregular in thickness, and glomerular vessels like in this image or in this image. But interestingly, in this lesion that is flat on the left part and raised on the right part, you can see that some of the glomerular vessels will change into hairpin-like vessels since the lesion is thicker, and since it is possible then to observe the papillae from the side and not from above. Glomerular aspect is also observed in periungual Bowen's disease, and the squames could be very prominent in some cases. In some cases also, we can observe in Bowen's disease pigmentation. This pigmentation has a very specific aspect on the edge with these lines of dots that are highly suggestive of Bowen's disease, especially in heavily pigmented patients. But pigmentation can be also irregular, like in this case of periungual Bowen's disease. In case of early squamous cell carcinoma, what we will observe is these follicular plugs, and we will observe two different aspects: crateriform squamous cell carcinoma and keratinizing squamous cell carcinoma. In crateriform squamous cell carcinoma, on the edge, we will have long border aspect, and in these long border aspect, the subpapillary horizontal plexuses will be prisoners and pushed up by the tumor. And this is why in the periphery of these lesions, we often observe these arborizing vessels. Again, arborizing vessels. But if we have more keratotic type of squamous cell carcinoma, then the vessels observed will be mostly the vessels of the papillae. If the papillae are long, we will have hairpin-like vessels, and if they are not so thick, then we will have glomerular vessels, and often the two are associated within one lesion, and this also depends on the angle of observation of the tumor. But in very little lesions like in this one, it is possible to recognize the vessels of the papillae right in the center that give interesting information in favor of a keratinizing tumor, and why not a squamous cell carcinoma. In these flat lesions, it is important also to rely on the presence of these white circles that are almost the only feature in this case, and diagnosis is very helped by these white circles. In more raised lesions, then the keratotic plugs are so big that you can see almost only keratin, and in some cases these whitish cysts also indicate the presence of a deeper lesion. So superficial lesions are diagnosed on the basis of the vessels, but also the white circles, whereas thicker lesions are based on the aspect of the vessels in the periphery, the presence of purpura and some pigmentation. Then we will deal with advanced squamous cell carcinoma, And in that case, you will admit that dermoscopy is not of big help. The tumor is thick, and in fact, the image we will observe is non-specific. We observe an atypical vascular structure with all the possible definition, multiple vessels, presence of milky red areas, presence of linear and irregular vessels. This aspect is highly suggestive of a malignant tumor, but it could be ulcerated basal cell carcinoma, squamous cell carcinoma, Merkel cell tumor. It could be a melanotic melanoma. It is impossible to tell on the basis of this image. To be complete, squamous cell carcinoma on the skin is not limited to these classical pictures. We will also observe squamous cell carcinoma in the nail unit, in the periungual unit, and this needs also dermoscopical criteria, but this is a long story. Squamous cell carcinoma is also observed in mucous membranes, and again, it needs a specific description. So I come now to my conclusions. Dermoscopical semiology is mostly based on criteria corresponding to vessels, keratin masses, and some pigmented lesions do exist. Dermoscopy is somehow helpful in differential diagnosis of squamous cell carcinoma, mainly in case of Bowen's disease and early squamous cell carcinoma, but it's far less significantly interesting than in melanocytic tumors. Many confounders exist, especially when you observe an atypical vascular structure, including a melanotic melanoma, basal cell carcinoma, but also a benign condition, the pyogenic granuloma. Thank you very much for your attention. See you next year. Goodbye.